Okay, we are live. So hello everyone, my name is Dr. Forrest Beck. I am the Director of Certificate Programs here at Southwest College of Naturopathic Medicine and also an Associate Clinical Professor. And today we are going to be talking to Dr. Tyna Moore, who is up in, is it Portland or Beaverton actually, or where are you at?
I'm right on the edge, so we'll just say Portland.
Okay, let's say Portland, but she's coming to us from Oregon. And I'm super excited because we have a lot of things to talk about today that I think are really relevant. SCNM is hosting a Regenerative Injection Therapy workshop series. The first one starts November 20th in the fall here, and they're going to go through next late spring, summer. So you can go to our website and look for that information, scnm.edu. But today's focus is on one of our faculty members for that workshop, Dr. Tyna Moore, who has a ton of experience in the area, but also a real passion for injection therapy, obviously. And we're going to be learning a lot of kind of her history and how her practice has evolved into what it has become today. So welcome, Dr. Tyna Moore. Thank you for joining us today.
Thank you. Thank you for having me.
So first of all, can you tell us a little bit more about kind of your education, where you, because I know you did something a little bit unique among naturopaths as far as getting a dual degree. But can you tell us kind of a little bit of the history, kind of what led you into going into this field altogether?
Sure. So my background is that I was a really sick child, and Mom drugged me around from specialist to specialist, and the doctors that took the best care of me, who I considered my primary care physicians, were always chiropractors. And they were the ones who really were my family doctors growing up, one after the other. And that was how I learned, I guess, about alternative medicine, and one of them was an acupuncturist as well, so there was some of that going on. And then many years later, flash forward, when I was an undergrad at Portland State University, I was working at OHSU, Oregon Health Sciences University, in the research department of the Alzheimer's and dementia group. And so that's where I was going to become an MD. I decided I was going to be an MD from the age of 12. And because I was such a sick little kid that I decided there had to be a better way to do things. So was going the MD route, and then in 1997 was told by one of the head neurologists up there that if he spent more than 5 minutes in the room with a patient, he was losing money because of the way the HMOs were going. And that just broke my heart. So I finished up undergrad at U of O, came back home to Portland, was living at my parents' house, bit distraught about what I was going to do with my future, and applied for a job with Noel Peterson, who is also part of the faculty of these regenerative injection courses. This is a funny story. You'll like this. So I applied for a job with him, and I was interviewed by him twice, and I believe his office manager, and they really liked me, but my background was too allopathic. I didn't have enough. And there's this unspoken beef between the chiropractors and the naturopaths that literally does exist, and I felt it on both sides as I went through both programs, and so maybe that had something to do with it. I'm not sure, but I didn't get the job. And a few days later, I got a phone call. I still remember it was on a rotary phone at my parents' house. And I picked up the phone, and on the other end was Rick Marinelli's voice. Noel liked me so much that he faxed my resume over to Rick.
Oh, awesome.
Rick called me, and I walked into his office the next day after he was done with patient care. When you see someone and you've known them forever, it's just one of those rare moments, and that was Rick. So I was 22, and I started out as his receptionist, and I spent many years doing that on and off, and just couldn't believe what I was seeing. He had me doing the ordering for the clinic, and there was these huge needles and all these solutions, and I didn't know what any of it was, and I was so interested, I started kind of reading through patient charts, and his handwriting is despicable, so wasn't getting very far there. And finally I said, can you tell me what you're doing back there? And he showed me, and he dropped a 4-inch needle into somebody's spine, and I about fell over. But these were patients that were literally coming in wheelchairs, and within a few treatments walking out, signing their own checks. He was an acupuncturist as well, and just, he was a Jedi. So that was how it all started. I many years later started chiropractic college, much to his dismay. He was not very happy with me about that. And
Why?
why? I think he wanted me to have a full scope of practice, and he wanted me to be able to do what he did, you know.
Yes.
So I spent, I think, 5 quarters at the Chiropractic College here in Portland, University of Western States it's now called, and just could not figure out why they never addressed, they just really didn't at the time. They were not addressing these chronic conditions with dietary recommendations or any of the things we do as naturopaths. And I knew from working with him for so long that there were other answers to this. The other piece was that I wanted to know why we had to keep adjusting the same joints over and over and over again. It didn't make any sense to me. And Rick pointed out very clearly it was because of ligamentous laxity. I was like, oh, makes sense. Well, nobody wanted to hear that over there. Nobody really talked about the ligaments in chiropractic college.
I bet.
Which is weird. You know, you'd think musculoskeletal medicine, I mean, we address everything else but the ligaments. And so I jumped ship. I went to SCNM, the naturopathic college here, and spent a year there and realized that I really missed my tribe over at the chiropractic college.
Oh, really? Oh, okay.
You know, it's just, the chiropractors are generally, it's a rowdy bunch. It's a rowdy bunch of guys. And the naturopathic school is predominantly female and
yeah. Very different vibe, huh?
Very different vibe. So, and I'm a tomboy, so I've always been a tomboy. And so I went back over there to take my adjusting courses here, and they said, why don't you be a guinea pig for this program we're trying to build, which has not come to fruition, but they tried. And so I went to both schools concurrently for several years and finished up. And really, I went to naturopathic college because I wanted to inject. I wanted a license to inject. And I learned so much more along the way, of course, and I learned the heart to my medicine, but I really wanted to be able to inject if I needed to. So, and
cool.
I knew I needed both degrees to be even remotely as good as Rick was. So he was pretty awesome at musculoskeletal medicine. So
yeah.
That's how I got here.
Okay, well that's really interesting, and again, this is information I wouldn't have gotten from your website, or that you took a pause from the chiropractic program. I thought from looking at your CV and stuff and reading your information that you did them both concurrently the whole time, and that was kind of how it went. So that's interesting that you just took some time off and tried the ND program and then went back and stuff and finished them up together.
Yeah, it was brutal. I wouldn't recommend it for anyone. It was. Yeah,
I think that's what most people say when they go through dual programs.
Not terribly good for my health.
And I know SCNM starting an MPH program together with an ND program next fall, and I'm curious how that's going to, be balanced as well. So
it's tough.
Well,
and
cool.
So just real quickly to flash forward, when I got out of school, we were in the middle of recession, and Rick was going to take me on as a resident, and because of the way that the recession was happening, he said, you know what, I want you to go out and I want you to get some experience. I want you to be more confident before you come in and join me. So the whole goal was really that I would one day work with him, and we both knew that. And then, flash forward a few more years, and he ended up coming down with cancer, and I took over his practice, and I managed that for 2 years, and then he gifted the practice to me, and he passed away. So basically whatever I could get downloaded over the course of nearly 20 years from him, if anyone knows how he did things, it was me. I was the little birdie on his shoulder for a long time. So
well, and that truly is a gift. I mean, that's really amazing that you're able to be in that position, and I'm sure it wasn't an accident, really.
It doesn't feel like it.
Yeah.
Kismet.
Well, so how have you? What are you doing now? I mean, what are your main practice modalities when you're seeing? What's your practice look like right now?
So a couple years ago, after his passing, I sort of have what I called a naturopathic seizure. I really just got real with myself and realized I was overworking and was headed for an early grave myself because I was working so hard. And I'm a single mom, and a solo practice owner. And I decided I was going to do what I came here to do, which was to inject. I came here to inject. I wanted to be very good with my orthopedics and my biomechanics, and I wanted to do prolotherapy and regenerative injection therapies. And so I cut everything else out. I had a really great, thriving practice doing general naturopathic care and hormones, bioidentical hormone replacement, but I referred all of that out and just focused on the injections and decided to step up my game and get further, as much training as possible. So that's what I've been doing the past couple of years, and it's great. It's great. I'm doing what I love. It's fun, and everything about it is fun and rewarding, and getting people out of pain is so cool, and getting them on to the rest of their life. And what I found is that I spend a good hour with the patient as I'm doing some of these procedures, and I can interject all the good naturopathic care in there. I can interject the anti-inflammatory diet. I can interject all that information, and if I can't manage it, if it's something that they need more care for, I just refer them to the naturopath in my office, Dr. Sarah Wood, and she takes care of that piece. But it's great. I still get to interject all the good nature cure stuff for them.
Well, yeah, it's got to feel like you're providing comprehensive care as opposed to just, sticking a needle in somebody and forgetting about that.
And then I also am quick to identify what's wrong. That's what I love about being a naturopath, is I'm quick to identify systemic causes for pain. And roughly 50% of my patients don't get injected. I send them either back to their naturopath or to somebody who can manage their care in a functional way, just to get that piece handled, because 90 days of an anti-inflammatory diet and having your hormones optimized can mean everything between these regenerative injections working or not working. And the bottom line is that we want good clinical results. We want safe clinical results. We certainly don't want to send someone into a flare. So having that piece managed is critical. I may be talking myself out of a lot of business, but patients respect me, and that is my that's how I'm known in the community. That's my reputation, that I don't BS. I'm going to tell them exactly what's wrong with them, and I'm going to get them into the right hands efficiently. So that may have nothing to do with me or my needles, but we just want to get them into healing mode. So.
Well, and that's got to be a much more sustainable practice model, I would think, personally. And it, when we were chatting offline about this, how if somebody's coming in with an autoimmune condition or something, and that's not necessarily a good candidate for RIT right away, maybe down the road once you get some of these things addressed. But it brings up the point to me, when I just heard you say this, how often do you think that's happening out there, where a lot of docs that are doing Prolo or RIT or PRP or whatever it is, they're saying, well, let's go ahead and start. They don't know, they don't have those systemic antennae, to say, look, there's something else going on here. We're not going to get the best results. Let's have them go address this first and then come back to me. You want to take that one?
I think that's really common, and I see it even amongst other naturopaths sometimes too, who are just quick to jump the gun. No fault of theirs. It's just, if we're not getting good clinical outcomes, then these treatments don't get a good reputation. And so patients will come to me. I get a lot of patients who have seen other docs in town, and they say, oh, I had Prolo, it didn't work. I had PRP, it didn't work. And it's like, I'm looking at them going, well, you have no testosterone and thyroid on board. Of course it didn't work. You're not in any kind of anabolic healing state. So not to say I have all the answers by any means, but I do think that happens, and I think it to the detriment of the treatments.
Sure.
And so, they get blown off as not being effective, when in reality it just wasn't the right time to apply the treatment to that patient. Or maybe their pain was not at all biomechanical. I see that all the time. Anytime someone comes in with bilateral anything, both hands hurt, both hips hurt, both knees hurt, something systemic is going on there.
Yeah, you've got to be thinking systemic, huh?
I don't even care if they have MRIs to prove the degeneration in both joints. Something systemic is happening. It's so rare that a bilateral cause is purely biomechanical. And so addressing both of those concurrently or one before the other I think it's critical. Well, and it's regenerative. That's truly my vision and definition of regenerative medicine. So.
Yeah, and we can very well use these terms without not only understanding them, but then applying them. And like you said, we want more naturopaths, hopefully, that are interested in doing musculoskeletal work to be doing injection therapy. And if they don't have this awareness, they're going to just go down the old prescription road of, okay, let's just inject that joint, and see what we get. when in reality they should be assessing all of these other things and applying it, you know, at the right time, like you said. So that timeline, I think, is hugely important.
And I think we're perfectly geared for it. I don't think there's anything more. It's funny that, you know, Prolotherapy got its start with the osteopaths, and that the medical doctors are the ones really running with the PRP and making it popular, because there's nothing more inherently naturopathic than getting the vis naturae, you know, priming the system, getting the patient's vitality to work for them, or taking their blood, concentrating out their platelets, and injecting that into the damaged tissues. I mean, that's taking the vis and concentrating it down into a syringe and putting it where it needs to go. There's just nothing more naturopathic. These are the most naturopathic treatments when it comes to injection therapy that I could think of. And I got a lot of slack in school from people because they said, oh, you know, what you want to do is so aggressive, and it's
I bet.
And this and that. And I was like, no, it's so naturopathic. It's brilliant, and you're calling the body up to heal itself, using its own tissues, its own immune system function. And these treatments are only as good as the person's immune system and their ability to mount a response to the treatment. So that's why these studies in PRP, in my opinion, are complete nonsense. We're pushing so hard to have all these great studies done, at least in the orthopedic community, but we're comparing apples to oranges. Your platelets and my platelets are two entirely different beasts. And my platelets versus a postmenopausal obese woman who drinks Mountain Dew every day are completely different beasts.
Yeah, absolutely.
And so there's absolutely no way to do a double-blind, controlled placebo. There's no way to do it. And even if you shoot saline into a joint, you get an effect.
Right.
So I think the study, there's no way to actually do it. And no one ever talks about that at the conference. They actually call me the naturepath now. I'm like the token. They're like, hey, naturepath, because I'm over there saying, hey, who are these patients that you did these studies on, and what's their chemical milieu?
Yeah.
These are only as good as their chemical milieu. So that's where I think naturopaths have the upper hand, and learning these procedures just go right in line. If naturopathic physicians are interested in musculoskeletal medicine, these treatments go right in line with that belief.
Yeah, absolutely. Well, let's step back a moment and just, let's say some of the new students or a beginning student or somebody who's even considering learning more about this, can you give us an overview of the different types of regenerative injection therapies out there? You know, what are the different categories that you have in your practice?
Sure. So I tell patients there's tea, coffee, and espresso. And depending on the patient and the condition and how long they've had it and how bad it is, we're not sure what they need until I evaluate them. But the tea would be the Prolotherapy. It's been around since the 30s. It's tried and true. It is a technique as much as it is a solution-based treatment. So when people refer to Prolotherapy, most often what comes to mind is dextrose Prolotherapy, which is the solution most often used, although there are other solutions. There's sodium moreuate, pumice. The old school docs used all kinds of things. That is a treatment where basically we're trying to proliferate the area, so the needle itself counts, and ligaments and tendons have a poor blood supply. We know this.
Yeah.
So what we want to do is go into these ligaments or tendons where they're damaged, and that's where most people's pain is. If you are a musculoskeletal medicine doctor and you were to take that patient's painful muscle and follow that muscle belly up to its enthesis point, where tendon meets bone, you're going to find the most tender spot there. That's where we inject. So doesn't matter what's in our syringe, that's where we inject. So Prolotherapy is a dextrose-based generally, and what that does is it's hyperosmotic. It calls the immune system into the area. Basically, it says, hey, wake up. We've got this hyperosmotic solution. The body's being called in. The second thing it does is we're proliferating with the needle. We're causing microtrauma and blood, which is great. Blood's always good. Blood always heals things. And the third thing it's doing, which we've only just recently figured out, is there's the TRPV1 receptor, which is the capsaicin receptor. And nerves have these receptors. It's when you apply topical capsaicin, that's the receptor that is being affected. Well, dextrose sits on that receptor as well. And so what dextrose is doing is decreasing neuroinflammation, which is brilliant. This is why when somebody gets treated with dextrose Prolotherapy, and the local anesthetic has long worn off and the pain is still gone, we couldn't figure that out because these are supposed to be regenerative in nature. We're asking with that dextrose, we're asking the body to build new and healthy tissue.
Right.
How could that be happening so quickly? But now we know it's the dextrose having this neurogenic effect, which is awesome.
That's really cool.
It's really cool. So I actually put dextrose in almost everything I do now. It doesn't matter if it's PRP or not. There's always a little low percentage of dextrose in there because it's just magic. It also works as a local anesthetic. It's great stuff. Cheap, wonderful, efficient, and that's where I think most practitioners need to start. If you don't know how to do prolotherapy, you don't have any right picking up a syringe of anything stronger. So prolotherapy is also a technique where we inject all of those tender spots. So rotator cuff, for example, people come in with an MRI saying, I have a rotator cuff tear.
Right.
Or that is just a simple tear on the supraspinatus tendon. That is not the whole problem. If you've got that, you've generally got a whole rotator cuff issue. So we need to treat all of the ligaments and tendons of the rotator cuff, anything that's tender to palpation, anything that's involved, and also intra-articular, also the labrum, the joint capsule. It's a series of injections. That is prolotherapy technique, old school. That's how I was taught. That's the way it's effective. You can bump that up to PRP, which is basically taking the patient's own blood, concentrating out the platelets, which have many known growth factors, and injecting that concentrated solution back into the injured tissues.
Mm-hmm.
That is the same technique that I use, though. I use a prolotherapy technique with my syringe full of platelet-rich plasma. So that's where I think we've got a huge divide in the orthopedic community, because a lot of orthopedic doctors are simply putting a small aliquot of PRP underneath ultrasound-guided imaging into that supraspinatus tear. That's it. Call it good. Charge the patient. Go home. The patient shows up in my office and says, I had PRP. It didn't work. Well, you know, what was your what technique was used? Did you get any? It's not just shooting juice in the joint. You got to treat the whole. You got to treat all the involved structures.
And why do you think that is, Tina? That they do see just that isolated tendon or ligament and that tear that goes on there, and just only treat that part versus assessing the whole joint?
Well, it's really interesting because I have a lot of chiropractor colleagues who think prolotherapy is quackery, but they think PRP is very cool. PRP makes sense to them. The idea that we're using the body's own blood to cause a healing response makes sense to most practitioners and physicians.
Yeah. Right.
The concept of prolotherapy, of calling the immune system up to cause a low-grade inflammatory response that's modulated to heal tissues, that doesn't make as much sense to them. And they think of it as almost scar therapy, or that we're causing some kind of contracture down, and that's misinformation. It's not true. It's regenerative. It's causing new, healthy tissue to be stimulated and grow, and not in a haphazard, inflamed contracture sort of way. So I think they don't buy the idea of Prolo, but they buy the idea of PRP. And done to an objective finding is legitimate in their eyes. I have an MRI finding of this, so if I inject there, my bases are covered.
Gotcha.
Prolo is also hard to learn. Knowing how to palpate, I mean, palpation is king with prolotherapy, and so is knowledge of anatomy and biomechanics, and so that's a whole lot harder route to take than just pulling that ultrasound probe out. And I can see them at conferences. The guys who I call them ultrasound jockeys, they have no forearm muscles. They do not work with their hands.
Oh, that's funny.
They do not have forearm muscles or veins in their hands. They have no manual medicine skills. I know they're ultrasound jockeys. And they might be brilliant with the ultrasound and do some really cool stuff with it. But when it comes to a prolotherapy technique, I think it's critical that that be taught first and learned, just like in any sport. You learn the basics well. You cannot be a good hockey player. You can hit goals all day long, but if you can't skate and you can't manage the puck and you can't be a team player, then you can't play hockey. You know, same thing in my opinion with PRP and stem cells. If you don't do Prolo and you don't know how to do it well and you haven't done hundreds of cases, you really shouldn't be picking up stronger guns and shooting them.
So again, that's so interesting with the ultrasound versus palpation, because you would think that ultrasound does give you a lot greater aid, but it really does come down to what you palpate and where you feel. You can't ultrasound a painful area. All you can see a tear or anything like that. It doesn't give you that information. So
exactly, and you can find all kinds of horrible objective findings on ultrasound or MRI, but that does not mean it's the patient's pain generator.
Yeah.
Or they have both. I mean, missing a whole rotator cuff issue, it's sometimes the most minor things like the inferior glenohumeral ligament. posteriorly is the thing that is taking them down when I hit it with my thumb. So, you know, Rick always said, "This is my MRI."
Yeah.
So, and it's so true. Without proper palpation skills, I don't think that you can have a successful regenerative injection practice.
Well, and it's so much less expensive, you know, this guy versus an MRI too, huh?
Yeah, I'm right. I always think I learned to inject blind. We call it blind, meaning without ultrasound guided. That's how I learned. I did thousands of cases before I ever picked up an ultrasound. And I'm so glad for it, because when the ultrasound is not giving me the image I need, or I can't quite get it because the patient tissue changes, and somebody who's really hypothyroid, for instance, you can't visualize much under that probe. They've got so much edema in their tissues. I'm so thankful for these fingers and thumbs and my ability to do it without using ultrasound, because I couldn't imagine. And plus, how helpful would you be if you were, I don't know, without an ultrasound?
Right.
That's all you knew. So people always want to run to the PRP, and they always want to run to the ultrasound. Those are very expensive routes to take, and I think much to their detriment, because being a good prolotherapist, old school, dextrose. I was just at this conference in Denver for the American Association of Orthopedic Medicine, and Angela was there, and they were, you know, they started with one of the first lectures was by Mayo Friedlich, a well-known prolotherapy doc, great guy, and he basically said, if you don't have a good handle on prolotherapy, you have no right touching anything else that we're going to go into today. And as the lectures progressed during the day, I mean, they got fancier and fancier and fancier, and just, they're doing some crazy stuff with stem cells now. And Dr. Andrew Kogan raised his hand, who's one of the oldest prolotherapists alive still. He raised his hand and he said, you know, 95% of what walks through your office door can be handled with a $2 bottle of dextrose. And
that's pretty telling right there, isn't it?
Yeah, so I think learning that well, and that's what these workshops are about, is making sure that we have a handle on that, and that the people that are, the doctors that are taking these workshops and learning from us have a handle on that, because that's really where the power of these treatments come in.
And again, it's, sorry to interrupt it, it's ironic to me, you know, again, we were talking offline about ultrasound and the steep learning curve that goes along with a diagnostic ultrasound, but people don't want to use their hands, which they have, you know, it's not high technology, or maybe it's the best technology we have. They're not wanting to take the time to learn how to palpate effectively.
Right.
Instead, they'll put all that time into learning on a piece of equipment. And again,
Right.
I get the tech stuff. I get that that's exciting, and it's, you know, it's fancy, and it's cutting edge or next generation. But I still think you have to have your physical exam skills down to complement, and let the technology complement that versus the other way around.
Absolutely. And the truth is, you can shoot this stuff, I don't care how fancy of a solution you have in your syringe, if your diagnosis is not correct, you're not going to get anywhere. And so diagnosing these things is key.
Yeah.
And being able to, having a lot of students and practitioners contact me weekly and say, how do I get started in this? You clearly are doing it. How do I do this? And I tell them all the same thing. Pull out your anatomy text, know it like the back of your hand, and know and palpate, and really get a handle on those orthopedic tests, because they do come in very handy. And I think that's where a lot of my success has been, in that my chiropractic training was so heavy on that. It was so heavy on neuromusculoskeletal medicine and diagnosis that I always say I diagnose with my chiropractic degree and I treat with my naturopathic degree. Because
Very cool.
You know, I can quickly come to an efficient diagnosis, and then as a naturopath I can see whether it's systemic or what systemic issues might be involved in interrupting whatever process I'm trying to push forward, and then, you know, I pull my needle out if I need to. But it really comes down to just having a good handle on how the joint's moving, your understanding of the pathology that can occur within that joint, like what are the top 3 things that could go wrong, having a good handle on diagnosing that without an MRI, without any fancy imaging, and then can you palpate the tissues? Gotcha.
Well, and so we were in the middle, I think, of the Prolo, then PRP. You were explaining those things, so let's finish that off, and then we'll go into some of the other topics we wanted to discuss.
Okay, so backing up a little into PRP, PRP is magic, but it's only as magical as the person it comes out of. So if I can get, you know, a 20-year-old male healthy athlete who's eating paleo and clean, that is like the most magical PRP. That's good stuff.
Is this going to be like, you know, the fertility clinics that are having sperm donors, you know, and they're looking for that 20 to 30, you know, that's fun.
I've met a few patients like, I wish I could use your PRP. I've thought that. No, but it's a magical stuff, and you can put it virtually anywhere. There's no contraindication because it is the patient's own solution. They're not going to have any kind of drug reaction to it. There's no reaction. Except inflammation. If you take an inflamed patient and pull out their inflamed blood and concentrate it down and do a super concentrate and put it into their inflamed body or their inflamed joint in particular, you have a hot mess on your hands. That's not good news. That's not fun. And I have gotten much more careful about pre-screening those people. I do some really advanced diagnostic testing sometimes, and then once I get the results back, they're in Dr. Wood's office going over the results.
Gotcha.
Because I can see it. I mean, I can see it walking in my door that we are going to have a hot mess on our hands if we.
Yeah, and you don't want that. Huh?
And sometimes people will really push it, and people who fly in from out of town, that's tough, you know. So PRP is great. Platelet-rich plasma, 20-some known growth factors, all do different things, and works really wonderfully. Regenerates tissues, been shown in studies to regenerate tissues, ligaments, tendons, cartilage, you name it. And then the step up from that is stem cells. And there's two main types. There's adipose-derived, which are more rich in stem cells, but harder to access because of the cell wall of the adipocyte. And then bone marrow concentrate, which has less stem cells, but is free to be used by the body. I don't do the bone marrow for a couple reasons that I don't necessarily want to get into. One being I don't really feel like drilling into people's bones. It's not.
I know there's some interesting videos on YouTube of people using the drills, and then one guy just using a hand, you know, kind of a hand.
There's all kinds of ways, and I've been taught by some great teachers. I'm just not feeling it. I have a really healthy patient base. I've got a great practice. I've got healthy, generally fairly fit people, and they're people a lot like us. You know, they start to get a little bit up there in age, they're active, and they're like, hey, my shoulder's really bugging me, or my knees really, you know, or even if they're 70 or 80, they're like very active, they've been active their whole life, and their knees are just giving out. When you start to go, bone marrow is the last frontier, and that's when you really start to invite some severely degenerated cases into your clinic, and I'm not feeling it right now. That's not. I like where I'm at. You know, I have a busy practice as is. I like the adipose stem cells because there are more of them. There's some political stuff we don't have to get into based on if they're available for use, or if you know, the FDA allows you to change them at all. That's a whole other topic. But I look at it as cushion. I'm putting a layer of cushion into that joint, which is rich in stem cells. It's a niche. It's a biologic niche which will hold the PRP in place, which is full of growth factors. So basically seed and feed with almost like a mesh. That's in my head what I'm thinking. And I place that strategically where I need to. Basically, you call it a fat graft if you want to, that's rich in stem cells and growth factors. And I get that to the tissues that need it. And the results have been great. People, great. I am not finding a lot of people failing care on that one. That's a great one, especially if we hit it on the front end or the back end with some PRP. So,
gotcha. Where are you harvesting from for your fat cells, your adipocytes?
I try to go from the belly if I can, the belly or the flank. That's where the mesenchymal stem cells are richest in that area. You can take it off of the gluteal folds or other areas, but I'm not a plastic surgeon.
Right. Well, and most people have a little belly fat that you can get to, right?
Yep, and that's where the ultrasound's handy because I can see the depth of what I need to do and get you good. And that's, in truth, I think if you're doing PRP and stem cells, you really should not be doing that without an ultrasound because those are expensive treatments for patients, and we need to make sure that we're getting that solution. I think we owe it to the patients to have the training and the machinery to get that solution where it needs to go and not be guessing.
Yeah, it's definitely another step up in care.
Yeah, so, you know, I did a lot of PRP without ultrasound. I'm glad to have it now. I think that it definitely serves me better. Definitely for the stem cells, though. I think the machine is critical.
Gotcha. And you know, there's the general, I guess, understanding that the fewer with prolotherapy, you need to do the most treatments, PRP fewer, and then stem cell even fewer. That's generally the line of thinking, correct?
Yes, I tell patients 4 to 6 rounds of Prolo. And the thing that I don't love about that is, like I said, most of my patients are active, and and just from my own experience, I really think it's necessary to take about 2 weeks off of activity, off of sport, after following any of these procedures. And with Prolo, that's kind of a bummer because I'm big into strength and conditioning, and I'm big into movement as medicine. You know, motion is lotion. And so if you are taking somebody off of something for 2 weeks, and then they get to go back to it for 2 weeks, and then we inject, you know, we inject a month apart with Prolotherapy, that person's really not getting any opportunity to rehabilitate that joint or that region, and probably experiencing some level of atrophy in the surrounding musculature. So to me, I don't know if that's always ideal, although there are lots of people I do Prolo on, and it's great. But they don't necessarily need 4 to 6 rounds. If somebody is really going to need the full rounds, I usually jump them up to PRP. I think it's a time saver, it's a money saver in the end, and still the 2-week break from sport, but then I give them several weeks, you know, a month to 6 weeks following injection to really get back to movement. And I think that's half the healing for people, just to get back to movement, because mechanoreceptors override pain receptors in the body, and as you know, you exercise. If you're not moving, you're generally hurting. So
right.
That's where I like PRP. I think so it depends on the patient, and when I give them both options, I let them choose if I think that Prolo will benefit them. Some cases are so severe, I send them right to PRP.
Gotcha. Well, and if you had to break down your practice as of this day, as far as percentage of people you do with Rolo versus PRP versus stem cell, what's that breakdown look like?
Probably 10% stem cells, and I'd say 70% PRP, and the other 20% Prolo. I will often use Prolo to start people. So if I am worried about them flaring, or it's also diagnostic. It's a much less expensive way to get your diagnosis. And going back to that proper diagnosis thing, if I'm not quite sure if things are not adding up the way that I would like them to, or it's a big region like the lumbopelvic region, for instance, and the hip, I mean, say they've got a lot going on, I can only get so much blood out of them before I start bleeding them to not feeling well. So that for the PRP, and so that's where I can pull up dextrose all day. You know, and dextrose works as a local anesthetic, so I'm moving further and further away from even using local anesthetics in my solutions. So I can do a broad treatment plan, and if I can centralize their pain down and get it down to a more specific region, just like any manual therapy that you do, if you're effective in your treatment, whether it's your hands or chiropractics or whatever, you will get the pain to centralize down. So if I can cut their pain and they get pain relief, and it lasts, if it's even 30 to 40%, and it lasts even a couple days, I know I affected the pain generators.
Gotcha.
And so I can come back with PRP and hit it with something harder. But I don't know what I would do without Prolotherapy. I mean, that's my, what in an insurance model will do just a lidocaine injection to the region.
Oh, Tina, are you there? Tina, are you there? Who is with me still?
I'm here.
Did you lose Tina as well, Angela?
Yeah.
I did,
Yeah. It looks like her screen's frozen.
And Michelle, okay. So hopefully she'll come back. I hope she knows she's off and isn't continuing to chat. Let me... Boy, I'm not sure what to do if I should... I have an ability to eject her, but I'm not sure if that's going to allow her to come back. Dang it. I was loving that, what she was saying, too. So let me... I'm going to message her. Tina, are you there? Okay, so it looks like is everybody seeing that? She dropped out. I think she'll probably come back. So bear with us. And I promise to get to you guys too. I'll make sure I give you time to ask questions if you would like that. Okay, Angela and Michelle?
Yep.
Mm-hmm.
While we're waiting for Tina, Angela, you were just at this conference in Denver.
Yep.
What did you think of it?
It was my first orthopedic medicine any gathering. I started doing a basics of injection therapy workshop with Tina in the springtime.
Oh, okay.
So I'm pretty new to all of this. And I thought it was really great as far as the information and research, but there's no like step one intro, how does someone actually do this?
Yeah.
So like Tina was saying, there were some presentations about really crazy bioscaffolding stem cell stuff. I mean, they're at step 50, and I don't, it's like, where's
Right.
step one? I just need step one.
Right.
And a lot of these are coming from sports medicine and other like orthopedic realms, and they may have prolotherapy as part of their training, and so that's why I'll be down there at the first workshop also in November, because we don't have that as part of our training, so this is just a good step one for me.
Yeah. Well, that's great. And I definitely want to. Okay. Okay, Michelle, you're there. I keep hearing somebody like try to get in. Do you guys hear that as well?
I
Yes.
did hear a noise.
Okay.
And it's actually saying incoming on my screen.
Is it? Okay.
Mm.
Hmm.
Let me see. Try again. Come on, Tina.
I'm here.
Oh, there you are.
You somehow got contacted to my business account again, not my personal one, so I decided to be smart and log into that. I'm sorry.
No worries. I was just chatting with you. I said, okay, try again, and that's why I said, okay, come on, Tina. I thought you were. Anyway, yeah, great. So, how much did you talk before you realized you weren't being recorded anymore, weren't on?
Oh, you guys all froze up, and I stopped talking.
Okay, great. So, do you remember where you had left off?
Did you guys hear the part where I said if you do Prolo, you can diagnose with it?
Yes.
Okay. That was basically it. So if I can provide the treatment, I can diagnose with it as well as give them a therapeutic benefit.
Okay.
Which
well,
is
I was asking Angela while you were off about the conference, and there are quite a few things I want to talk about still. But I know she said a lot of it was quite advanced. What did you find that you could take away from it and really apply to your practice, where you're at? And I know you've been in the business for a while, so what did you find useful and kind of cutting edge stuff that actually makes sense from a naturopathic standpoint?
the workshop in Denver?
Yeah.
I go just to hear the updates every year. I just want to hear what they're doing and see what is new in stem cells and stem cell research, and just the core group of faculty there are friends of mine, and they're all mentors, so I'm not sure if I glean too much out of it, except that some really fancy stuff is happening with stem cells.
Okay, gotcha.
That, there's just a piece of this that I don't feel like getting into. If you talk to Dr. Harry Adelson, who hopefully you'll interview, he has a surgical suite and does fluoroscopy guided imaging, and it's very technologically advanced. It's fancy stuff.
Yeah.
And I don't want to do that. You know, I like my, I'm trying to fix my lighting. I moved my computer a bit. There we go.
Yeah.
I like my,
I think we're good.
like my practice. I like my ultrasound. I like treating all the extremities. And I do a lot of spinal stuff too, but he goes into people's discs and puts stem cells into their discs. I don't have any desire to go there. Noel Peterson's even doing some more advanced things than I am, and that's great. I refer to him for those things. I like the simplicity of, I love Prolo. I love dextrose. I'm always feeling like we get into these conversations about some of these treatments, and I'm like, what about poor dextrose? Everyone's forgetting. And I think that is very true. I have gone to these conferences, and I find that they really jump into some more advanced things, and just the basics are not covered terribly well. And I think we're trying to we're trying to remedy that with these workshops that we're doing at SCNM. Is we want to make sure that we create talented and effective naturopathic and all kinds of practitioners, really, practitioners who know prolotherapy like the back of their hand, almost like a diplomate. That's what we're hoping with the series of these courses.
Yeah.
Is that it's almost like a diplomate in study, and then from there they can take it anywhere. They can get as fancy as they want, but when they show up at these big fancy conferences, they have a handle on it. And they always group the naturopaths together, and we always get to be a group at the workshops.
Oh, do they? Oh, that's interesting.
They do. They put together, and what I find is that often the naturopaths don't have the basics down. That's missing. I'm sure that there's MD groups that the basics are missing as well. I'm not saying we're bad compared to anybody else, but when I see it, I remember how Rick felt about it, which was frustrated. And so he had a series of courses before you even got to Natty, just on the basics of things. And so I have one course called The Art of Needling, where I try to teach just the basics. Yeah. And then from there, people can jump into Natty. But Natty will cover that as well. And we want to make sure that people come out of these courses with a good handle on each region of the body to be safe and effective. Safe is key. We do not need any adverse outcomes coming back on the profession as a whole.
Yeah, well, that harks back to what we were saying earlier about knowing when to do what, right? You have to know if you are going to cause a flare potentially. If you're doing, well, that's Prolo, you wouldn't, but the PRP you could potentially.
But beyond that, we don't want to hit any major structures. That's why you have to know your anatomy. You're not just looking for what you are going to treat. You're also needing to know what's in the area that you want to avoid hitting. Yeah. That's important. And so I was at a conference in New Orleans recently, it was the AAOM's annual conference, big, huge conference over many days. And there was one MD who got up and had to talk about adverse outcomes and loved the fact that he got to pause and tag it onto the naturopathic community, because it turns out there was a naturopath involved in this. And that's just unnecessary, because there are adverse outcomes in all the professions. But we want to make sure that we have a safe group of practitioners that we basically graduate from this program.
Absolutely. Well, can I ask you a couple questions about PRP if you have time?
Sure.
Because I think that's really cool, and on your site you mentioned some other uses for it aside from musculoskeletal. So can you tell us about some of the female health issues that where you're utilizing PRP? Yeah.
So actually, I just treated a male too the other day who came.
Oh, okay, interesting. Tell us about that.
Well, I'm treating lichen sclerosus, which is an autoimmune condition of the genital area primarily, and it's autoimmune, and it's very damaging to the tissues. They basically scar up and atrophy away. It's terrible, devastating conditions if you haven't seen it.
Yep.
And I'm up to my elbows in PRP and stem cells all day, and I had a friend say, hey, there's this guy, there's one other guy on the West Coast doing this treatment, and would you be interested in doing it? I was like, sure, I'm a woman. I've had lots of, training in gynecological conditions, and
yeah.
I don't pretend to be an expert down there. I don't do women's health, but I know my way around. And I also suffer from my own autoimmune conditions, not lichen sclerosis, but I know how damaging that those conditions can be and how frightening. And so I just kind of opened up shop for it and started treating it. Those tissues are very forgiving. So, and again, knowing what's not to hit and what is safe to inject. And the results have been wonderful. It's tough because it's an autoimmune condition, and so it can continue to progress if the patient is not doing all the other things that we teach as naturopaths, which is all the lifestyle management piece and the diet, etc. And a lot of these people are flying in from all over the country, and so they don't have a clue what an anti-inflammatory diet looks like, or that their gut could have anything to do with their vagina. So,
right.
But some do, or we get them on the path, and it's been great. Just even using PRP, but mixing the PRP with the stem cells and using that, because again, the fat, I'm using the fat as it's intended to be used, which is as a and not in every case, but in this case, I'm using it as a cushion. It's almost like a dermal filler, so I can help bring back some of the integrity and structure to those tissues that's been lost to the scarring and the atrophy.
What percentage change do you feel like you can get with PRP and stem cells in somebody who's had significant atrophy of that area?
It's tough because it really comes, we're doing this over like a 9-month period, and so it really comes down to what steps they decide to take for their health. Because often if their stress is high or their diet's poor, we don't get anywhere. That will happen. If they're really following the protocols, they get better. And it usually takes 3 treatments, though, which can get, that's a commitment for the patient, both time-wise and financially, to do 3 of these treatments. I have treated a few people who just had very minor cases with just the PRP. Just 1 or 2 rounds has been great. So
that's awesome.
I treated a pretty severe case on a male just recently, and I'm hoping the tissues looked much healthier after 1 round of just PRP, and then this treatment, which was last week, we did the stem cells along with the PRP, so we'll see.
Well, and I was on a shift this morning with the doc, and or just chatting with another doc this morning, she asked if when you do that, are you doing microneedling and then doing the PRP over, or are you injecting the PRP directly?
I'm injecting. I'm going subcutaneously and subdermal. And with the case of lichen sclerosis, what you're seeing on the surface is not just there is scarring that goes deep.
Right.
In many cases, and there's these fibrous adhesions all the way down to the pelvic floor muscles in some cases. And so one of the things that I didn't really mention with any of these techniques, the reason we are needling so much is because not only are we trying to induce collagen production and blood flow with that needle, but we're fluid dissecting a lot of these fascial adhesions. So whether I'm doing that around a joint or down in the genital area, I try to break some of those up with just the actual fluid.
Yeah, gotcha.
Yeah. I go all different kinds of layers because the thing about PRP is it spreads really easily. It's great. You can put it through a tiny needle. But with stem cells, you have to use a much larger gauge needle, which I think is, Rick always taught me the bigger the better with needles. The bigger the patient can handle, the more therapeutic benefit you're going to. Anyway, that needle with those stem cells might leave, in the case of joints too, it might leave some bumps and some irregular areas where the stem cells have been laid down, and it's almost like a dermal filler, but it always turns into normal, healthy tissue.
Gotcha. So it's kind of worth the short-term maybe flaw that somebody has.
Yeah, they're generally already having such issues that they don't mind.
So what sort of gauge needle is that with the lichen sclerosis? If you're using stem cells, you would be using in the pelvic region?
Probably 21. That's about the smallest I can get it through is a 21 gauge. Sometimes a 23 if their fat's really nice and soft and buttery. I know that sounds gross, but everybody's fat's different. It comes down to their level of inflammation. So some people have really fibrous, gristly fat, and some people have really smooth, buttery, healthy fat.
Sure. Well, it's like the butter we eat, right? It's there's all different types out there from Kerrygold on down.
Yep.
So before we start to wrap up, I want to open this up. Angela, Michelle, do either of you have any questions you'd like to ask Tina, Dr. Moore? Or are you just casual observers or listeners?
Just observing.
I think the only question that I would have is how we as students should go about getting the basic training. The program at SCNM is only offered to current doctors,
Mm-hmm.
and it's my understanding that the AOA PRM no longer accepts naturopathic physicians. So I was just kind of wondering where to start.
Yeah, that's great. That's actually a great question. Tina, if you don't mind just giving us an update on what avenues indies have available to them nowadays, because I understand it's closing, like Michelle mentioned, it's closing down some of these.
Yeah, I'm not super happy about that. Michelle, are you a student or are you a practitioner?
I'm in my final year at SCNM, so I have a little bit of time, and I've been, some of the graduates have been offering the basic classes, but and they're great classes, but we only get to cover a couple of joints, and
Sure.
so I'm just kind of looking for something more.
Well, the AAOM, American Association of Orthopedic Medicine, are very friendly to naturopaths, and in fact, they've had me talk at their conferences the last 2 years, and they're a great group of practitioners. The annual conference, you don't get actually any hands-on skills. The workshop that they have once a year, you do. But it's just, and Angela can speak to this, it's on cadavers, and it's very quick. You go through a couple cadaver body parts very quickly, and I would not say that that is adequate training by any means.
Okay.
Angela, do you have anything to add to that?
It is pretty cool to get to basically play with some of their really fancy toys, like do fluoroscopy and.
Yeah, that's very cool. Then I don't know about the other organization you mentioned, Michelle. I can't ever remember that long acronym. I don't know if they're the ones that ousted us or it was Hackett Hemwell. I think it's Hackett. I know Hackett Hemwell has closed their doors to naturopaths as of this year. Their reason being is both AAOM and Hackett Hemwell do a outreach or several a year where they go to Central or South America with a group of practitioners and learn prolotherapy over a week-long course there on the local people. And that has been an issue with the government accepting naturopaths and our licensing, and so we're not allowed to go.
Oh, gotcha.
And we're not allowed in those countries to treat. We're not allowed to treat in those countries as medical practitioners, and so because of that, Hackett Hemwell, that was their reasoning for no longer allowing us in their conference, which I think is because that's old school prolo. That's where that was the style I learned. That's what we're trying to carry forth with Natty. We did not Natty was an original group that was started by Rick Marinelli and Harry Adelson and Kevin Wilson and those guys back in the early 2000s as a response to some of this happening, being sort of pushed out of some of these organizations, and then it sort of faded away with Rick's illness and death. And we've revived it, not even knowing that this was coming down the chute, that the Hackett Hemwell thing. So I don't know. What was the other organization, Michelle? I forget. It's the osteopathic one.
Right, it is. It's the AOA PRM, so it's the
AOA PRM. Right.
American Association Osteopathic Prolo. I'm not really sure. Regenerative. I can look it up.
Right. No, it's okay. I know they're, I have not worked with them, but I hear they're great, and I hear they're very naturopath friendly. So I'm not sure if they're the ones who closed. You might want to check on that again.
Okay.
Gotcha.
So yeah, it's tough, and these are expensive courses, and so we tried to price this to be really fair and affordable. I know people have complaints about pricing on anything really, but we tried to make it affordable so that we could get this is open to chiropractors who can inject in the states that it's legal, and it's also open to MDs and DOs and practitioners who can inject legally under their license. And we wanted to make sure to get them really good, adequate basic training, because that's what's lacking. You're absolutely right. But I think this first year we need to do a trial run with just the medical practitioners, and we do hope to open it to students soon enough. I don't know when that timeline is. Forrest would probably know better.
Yeah, and that's something we're looking on. I mean, we're working on now, because we do. I mean, obviously, any college is going to have college is going to have students that are biting at the bit to get more training and not just what they get on shift on their clinical shift. So I definitely hear you, Michelle, and it's something we're trying to figure out what offering would be best. But initially, that we had to just cap it like Tina said, and just start with docs that already had a license. It was a lot simpler, and therefore we could start the actual training at a little bit different level than maybe worrying about somebody's palpation skills or anatomy knowledge and things like that.
Right.
And granted, there are all sorts of different levels of NDs out there, and DOs and DCs, as far as how active they are in using palpation skills and keeping that up. But that was the decision so far. So we'll see where it goes.
And Michelle, don't lose hope, because really it doesn't matter, and you've probably seen this with seminars, you train in something, and then if you don't have a patient population to try it out on, when you get home, if you don't have an active practice to practice these techniques, you lose them as time goes on. So really getting a handle on your anatomy and your orthopedic testing is so critical, and that is what will lead you in any of these treatments or modalities. So this would be the time to do it, which I know you got a lot going on already. But making
I was lucky enough to be able to practice Prolo on my husband over the weekend. There was a seminar we attended,
Nice.
so it was really fun. But like I said, we just are, like you mentioned, you use it or lose it, and you have to keep practicing. So
Right.
I appreciate your input and your information.
Well, and it brings up a good point, Tina. What do you think about the use of cadavers for learning? Do you think there's a value there, or are we better off, using warm bodies and just doing it on each other for?
That's a tough one, because the cadavers, you can't hurt them, but
Yeah, they don't give you that feedback.
I will tell you, there's an inherent sense when you drop a needle into somebody, that pain generator might just be a tiny fiber of that ligament or tendon, and I really feel I have an intuitive sense with my hands, and my needle is just an extension of my palpation with my hands, and I'll drop in and I know I'm not there, and I'll literally just, anyone who's taken a seminar with me has seen me do this, I'll just re-angle and then drop it back down, and they go, oh, that's it. I'm like, yeah, I know. I knew, and you can't learn. Plus, cadavers have such weird tissue texture, and a live ligament versus bone versus tendon versus muscle, belly, all feel very different. And a cadaver, they all kind of feel the same. So I think warm bodies I know it raises the liability risk, but I think it's far preferred, because you really get feedback from the patient. If you're hurting them, also it teaches you to be way less heavy-handed too. I see that so often with people starting out, as they have such heavy hands, and they're gripping with their palpation, and they're just kind of hack jobbing the whole thing. And there's an elegant, that's why I call my course The Art of Needling, because there's an elegance and an art to this, and it's about dropping in comfortably and getting comfortable with your body positioning, which is something we're not going to really be able to address in Natty. How do you hold yourself as the practitioner so you have the steadiest hands, and you're not putting extra strain on your spine or your back, and you're using the patient's body and your body appropriately to get the results that you want.
Well, and that's got to stem from your chiro training too, because I know you guys talk about that so much, to be able to adjust, lifelong, as opposed to just getting a few years out of your body. You're in it for the long haul, so hopefully you're learning those things well.
I treat a lot of chiropractors that I graduated with.
Oh, yeah?
Yeah, we're about 10 years out, and they're really starting to get worn out.
Shoulders and everything.
A lot of shoulders and wrists. But, and going back to what you're saying, people always ask me how long, patients will say, well, how long have you been doing Prolo? Because they don't think I look old enough. I promise I am old enough. How long have you been doing Prolo? And I tell them as long as I've had a license, but I was doing Prolo with Rick a long time before that, and helping him out, and and you're not supposed to say those things because you're not supposed to do them, but the more people you can get your hands on safely. And I think that SCNM has I came out and taught a course in Prolo a couple of years ago, and I think that some sort of club was started after that. In response to that, there's some kind, and I don't know if it's still going, but
yeah, I don't know either. I know there's, Michelle, can you speak to that? I know there's a sports medicine club and stuff, but I'm not sure if that's the umbrella that it's under or not.
So I'm involved in the sports medicine club, and that is where we pretty much get our information for the trainings that are upcoming. That's the only one that I know about.
Okay.
Through the school, yeah.
Well, Tina, anything else you want to add? I could keep talking to you for so long, because I feel like there's so much, so much we could chat about that I think is fun and exciting and cool that you're doing. But is there any last minute thought you had on something you wanted to add?
Yes. I am concerned about the profession as a whole, the naturopathic profession as a whole. I find more and more, and maybe it's because of the popularity of some of these online physicians, but I'm finding more and more physicians, MDs, who take a course through the IFM or some functional medicine weekend, and suddenly they're functional medicine doctors, and their websites read just like a naturopath's. And they really don't have, they don't have our paradigm. They didn't live it for 4 years of school. You don't just make a functional medicine practitioner because they learned, oh, the gut and the microbiome has everything to do with everything, right?
Right.
That concerns me. And I also am concerned that, at least at SCNM, physical medicine is not a big thing that's happening there. It concerns me because Rick Marinelli really brought pain management to the naturopathic profession. It was such a big part of who he was and what he contributed to our profession as a whole before he passed away. And just carrying that forward is so important to me, that we have procedures that we do that set us apart from everybody else. Because if you base your whole practice in functional medicine and that's all you do is talk therapy all day long, you're going to burn out. And I'm seeing it with my colleagues. I'm seeing a lot of burnout and a lot of lack of balance because people are getting sicker and sicker and sicker.
Yeah, that was me. I burned out for sure.
The stuff we're seeing, even when I graduated, the stuff that's happening even now, the rate of autoimmune disease being diagnosed is just astronomical, and it's so hard to treat. It's not what our elders were treating. It's not berberine and fish oil. This is some serious stuff, and I think having procedures under your belt that get you up off your chair, off your tush, because sitting all day is toxic, and moving around and using your hands and having that feedback and touching your patients, I think is so valuable for not only your practice but your sanity and your long-term well-being and your pocketbook. This isn't about making money. It's about sustaining a healthy practice. You can't keep your doors open on insurance reimbursements anymore. So having some procedures in your belt that are affordable to the patient, and trust me, no matter how much these procedures cost, even my most expensive stem cell procedures, they do not cost as much as having surgery does.
Yeah, not even close, huh?
Maybe they come close to the deductible, and in fact, that cleared their deductible for the year, but I think that it's important that we carry this forward and that we keep physical medicine as part of our profession, because it used to be a big part of, back in the day, all naturopaths were chiropractors and all chiropractors were naturopaths. And so just having that interest in that in your tool belt, you don't have to be an expert at it, but being handy to the patient and having procedures that are helpful to them and that are cost efficient and effective is really important. And so in girl power, we do not have hardly any female physical medicine practitioners. Angela, I'm so excited to see her at these other conferences because I just don't see, I'm like the token naturopath and I'm the token female. And it's a lonely old boys club, so that's it. A lot of naturopaths are female, right? And maybe not as much as SCNM, but at NCNM they're pretty much all female. So really,
you guys definitely have the odds in your favor already at the school. So it's just as a matter of developing, the women to really want to do this and show them, why it's important and why it's attractive.
Right, because taking care of really sick people all day, I don't care how strong your aura is or how grounded you are, how much you meditate, it wears on you and it makes you sick. And so having procedures that are efficient and fun and really helpful and taking people out of pain is so rewarding, because guess what happens when someone's knee gets bad? All the other things fall into place. They gain 10 pounds. They get metabolic syndrome. Boom, ba boom, ba boom. And on goes, and it all started, I have a blog post on it. It all started with
it's a great one.
Or a knee, And so for me, I feel like it's the ultimate preventative medicine, because 1 in 4 patients are going to walk into any doctor's office in the country for pain. So if you know how to manage pain, at least somewhat efficiently, you are 9 steps ahead of the curve and everybody else. So I guess that's my plug, is I really want to keep these techniques and these procedures strong in the naturopathic profession, but that will only happen if we have naturopaths doing them and doing them well.
And I think it just makes you a better doctor overall to be able to have good palpation skills, to be astute in biomechanics, to learn good orthopedic exams. I mean, all that can just complement, even if you don't want to be an RIT person or a physical medicine person. It's going to make you a better doctor, and so I think that's extremely important for students to, to
Sure.
recognize.
And even if you don't, even if you just learn a basic knee injection, ankle injection, maybe you don't even go near the shoulder. Maybe you just stick to a few basic regions, because a lot of people have ankle sprains, a lot of people have knee pain.
Right.
And I have practitioners who do that, and they'll treat 1 or 2 times, and maybe the end up in my office. It's great though, because, and I send them back when they're ready. But I think that just having that ability, if nothing more than being competent with your hands, I can't tell you how many naturopaths call me on a fairly regular basis, and they're like, I don't know what to do. I have a sprained ankle in my office.
Right.
They immediately x-ray them. I'm like, well, you just irradiated your patient, potentially very unnecessarily, because you did not know what to do.
Right.
So having some skills, just even if they're minor, just having, I think of like the old country doctor who could kind of handle a little bit of everything.
Right.
Having some minor physical medicine skills in your pocket makes you look way more credible and just makes you a better doctor overall. And I think it'll make your practice more fun. So,
well, I think it's about. Well, that's great, Tina. And I think it's knowing yourself too. And I think there's this. You mentioned how a lot of the trend nowadays is for a lot of doctors to go to a conference, and then the next day they've updated their website and they're the functional medicine doctor or whatever. And I think this is one of my pet peeves, is that we're in this day and age where I think it's sexy marketing to say we're experts in this, that, and another thing without having earned that expert status, by the years and years of seeing patients that goes into that typically.
I agree.
So, I think we're students, and as doctors we should be, I think, continual learners, but I think it takes a while before you can really earn that title of expert. Which brings up the tattoo. You want to tell them about your tattoo? I saw it on one of your videos.
My mermaid?
No. Is it Docere?
Oh, it is.
I thought I glimpsed a Docere on your wrist. So what's the story behind that?
So I'll tell you a quick story about this. It's gonna make me cry. I was burning out hard in practice, and Rick was sick and he was dying, and I was just in such a bad place. And he took my hand one day and he said, "Don't forget Docere." So I tattooed it. So that I won't forget it, so that I think about it, because he passed his legacy on to me, and it's really my calling to pass this forward to other naturopaths, because it can't just. There's a lot of us who've been trained by Rick Marinelli. I'm not saying I'm the only one, but we had a particularly close relationship and friendship for a long, long time, and I'm not going to say I was one of his kids, but I was kind of in the family, and it's just really important that this move forward and get. And I think he said that one of the last speeches he gave before he passed. He said, "Don't forget Docere." And I think that's what sets us apart as practitioners, is we teach our medicine to our patients so that they can live a healthier lifestyle. So that's what sets us apart from a functional medicine doctor who does just functional medicine. I mean, we really try to empower our patients. I'm sure a lot of doctors do, but anyway. That's what it is. I can't believe you read it. Most people look at it and they're like, "What's that squiggle?"
Well, I had a gut instinct, a guess maybe, but that's what it was.
Yeah.
Well, I think that's a great place to end. I mean, that's a great story. We can definitely do a round 2 in the future if you're interested. Sure. Or if we have other things to talk about. I think this
I'll get some better lighting in here.
It was great. Anybody else have anything to say, Michelle or Angela, before we go? Okay.
Nope.
All right. Well, thank you, ladies. Just another reminder that we are putting on the workshop November 20th through the 22nd on the lower extremities with Dr. Tyna Moore and other faculty members. Tina, if people are interested in the video, where can they learn more about you? Do you want to give out your websites?
Sure, it's easy. It's just drtyna.com. So DRTYNA will take you to my website. And there's videos on there on Prolo, PRP, stem cells, lots of blog posts about all of it, and just kind of my philosophy in medicine. And I just try to put some valuable things on there that are good resources for people to take care of themselves.
I think they're great. And your blog on the 10 steps for weight loss, which really isn't about weight loss at all, is wonderful. So
Thank you.
Check it out. Thank you very much, Tina, and I hope you have a great rest of the day. Thank you, ladies, for joining us.
Thank you.
All right, take care. Bye-bye.